My name is Katarina Stevens, and I'm a junior physician at the emergency department at Uppsala University Hospital in Sweden. I'm also the secretary for SWESEM Junior and active with the local group at Uppsala University Hospital. This section is going to be about different sets of criteria in making the ECG diagnosis. When reviewing the different criteria for ECG diagnoses, it's essential to remember the physiology of the normal ECG. So refer back to this section as needed and try to apply the physiology of the normal ECG in order to understand the physiology of the diagnoses reviewed in this section, and then thereby understand the physiology behind the criteria that we're going to review here. The different criteria that we'll be reviewing involves bundle branch blocks, hemifascicular blocks, enlarged atrium, ventricular hypertrophy, and then Skarbas's criteria. So starting off with a bundle branch block. A bundle branch block refers to an obstacle in the normal major electrical conduction pathways in the heart below the atrioventricular node. These blocks cause aberrations in the conduction of electricity, which may be caused by other more important pathological conditions. So starting with the left bundle branch block. The left bundle branch itself is the first stem off of the major bundle of His that leads to the systolic activity in the left ventricle. An intact conduction system will activate the heart to a depolarization pattern that starts from the left side of the heart and moves right because of a quicker conduction system on the left side. In the case of the complete left bundle branch block, there's a reversal of this depolarization for a moment, as the depolarization of the left does not receive direct information from the bundle of His, but instead from other intact conduction pathways. So essentially, it's a bump in the road that alters the planned path of travel for electricity and thereby systolic activity. This bump in the road will cause a widening of the QRS complex because the efficient method of ventricular depolarization is interrupted. The altered pattern of depolarization also gives rise to a Q wave in the precordial lead V1 and an R wave in the precordial lead V6, and thereafter the contraction of the right ventricle followed by the left ventricle is what gives rise to the wide R waves in the lateral leads and the characteristic RSR prime pattern in V6. Moving on to the right bundle branch block. Unlike the left, the right bundle branch may be in fact a normal finding in roughly 1% of the population. It's important to note, however, that a right bundle branch block may also be associated to pathological conditions, so it's important to take the entire patient into consideration before writing off the ECG finding as just a normal variant. Understanding the physiology behind the left bundle branch block that we previously discussed is helpful when you're studying the right bundle branch block because it's essentially the opposite, although not necessarily as broad of a QRS complex. And this is because the ventricular contraction still occurs as normal. And by that I mean from left to right. In the right bundle branch block, we will find M-shaped QRS complexes in V1 to V3, as well as deeper S waves in the lateral leads, including V6. So moving on to Skarbas's criteria. In the case of the left bundle branch block, the ST segment does not adhere to the same rules for strain and ischemia that have been brought up in a previous section. The segment tends to already be elevated, and therefore diagnosing an acute ST elevation myocardial infarction, STEMI, becomes difficult. So remember, a newly presented left bundle branch block should always be considered pathological. Check old ECGs to make sure the diagnosis isn't a new presentation. We're using here the modified Scarbassa criteria that can be used to diagnose myocardial infarctions in patients with known left bundle branch blocks. The criteria require at least one lead with at least 1 millimeter elevation, that's a 1 millimeter elevation above the baseline, concordant, and this term means in agreeance with, so think anatomy here, one lead with ST depressions, or the discordant waves with elevations more than 25% of the S wave amplitude. This is a bit confusing, but take a look at the ECG presented. We see here that in leads V2 to V4, there are significant ST depressions. No need to measure these guys, they're definitely more than 1 millimeter. These precordial leads are in complete agreement with one another, i.e. concordance, as they are showing signs of ischemia that reflects the posterior wall of the myocardium. Moving on to left fascicular blocks, or left bundle branch. These two fascicles are necessary to engage the more muscular left ventricle in a coordinated systolic movement. A good understanding of the anatomy of the heart here is essential when deciphering the two, as the left ventricle wraps around the heart. The posterior fascicle therefore gives rise to right lead readings predominantly, whereas the anterior fascicles are seen more directly in the lateral leads. Because the conduction pathway to the left ventricle is not completely blocked, like in the case of a left bundle branch block, the QRS complex may only appear slightly widened, i.e. 80 to 110 milliseconds, but not above the 120 milliseconds. Left anterior fascicular block. In the case of the anterior fascicle being blocked, the impulse spreads via the posterior fascicle, causing a posterior and to the right wave of depolarization initially. This gives rise to smaller R waves in the inferior leads and smaller Q waves in the lateral leads initially, before leading up to the dominating left spreading depolarization that presents itself with larger R waves in the lateral leads. Moving on to the left posterior fascicular block. Once again, we're doing the same thing here, but opposite. In a left posterior fascicular block, the electrical current spreads through the anterior fascicle to the left myocardium. The electrical current is dominated initially by an upwards and to the left pattern, causing small R waves in leads 1 and AVL, and therefore also small Q waves in 2, 3, and AVF. Following this, the depolarization spreads downwards and posteriorly, leading to larger R waves in the inferior leads and deep S waves in the lateral leads. Moving on to the section about enlarged atria. Starting off with the right side, atrium, also known as P pulmonale. Think P wave for the atrium and think pulmonary circulation when referring to the right side. Right side enlargement is quite simple, because thanks to the positioning and the anatomy of the heart, when the right atrium is enlarged, it produces taller P waves because of the altered conduction. Essentially, the enlargement simply causes more P wave activity, as seen in the inferior leads, referring there to 2, 3, and AVF. Notably, the term P pulmonale also reminds us of possible causes of the conditions. So think COPD or pulmonary hypertension as possible causes that give rise to this condition. Moving over to the left side, enlargement of the left atrium we also refer to as P. mitrale. Once again, the rule same but opposite applies. Enlargement of the left atrium, also known as P. mitrale, think mitral valve, causes a biphasic P wave due to the positioning of the heart and the funky shape of the left atrium when it's enlarged. When extensive resistance due to maybe ventricular hypertrophy or valve stenosis causes the left atrium to enlarge, it extends out laterally some. This causes a biphasic P wave in the inferior leads because of the deranged conduction pathway, but also a prolonged duration of the P wave since the electrical pathway has sort of been dragged out with this enlargement. Moving on to ventricular hypertrophy. When looking for ventricular hypertrophy in the ECG, remember what cardiac hypertrophy is. So here we're talking about an increase in muscle mass of the heart. This increased volume of the ventricular myocardium is going to display a lot of electrical activity during the systolic portion. That in turn is displayed in our ECG through tall amplitudes in the QRS complexes, and possibly slightly wider QRS complexes because it takes so much longer to activate all that muscle mass. The electrical axis here is helpful because it indicates when there is excessive electrical activity on one side or another that causes a deviation away from the normal axis. And by this we mean there's so much myocardium on one side of the heart that the electrical axis of the heart is shifted. So jumping into left ventricular hypertrophy. The left side of the heart, already being the dominating force that drives the electrical axis to normally be around 0 to 90 degrees, can be diagnosed using a variety of criteria. Note here we've used the Cornell criteria, which is one example. Another commonly used set of criteria is the Sokolov-Lyon, excuse my pronunciation, criteria. The Cornell criteria differentiates between male and female by requiring certain amplitudes to be obtained that reflect extensive electrical activity in the left ventricle. This is being the amplitude measured from the baseline to the R wave in AVL and from the baseline to the S wave in V3. Moving on to right ventricular hypertrophy, once again the same but kind of opposite. When the right ventricle is the dominating hypertrophic ventricle, the electrical axis will be shifted to the right, and we're going to see large amplitudes that indicate a lot of muscle mass on the right side of the heart. Therefore, the V1 lead will show predominant R waves, and the lateral precordial leads will display deeper S waves. And that is all regarding criteria. Thank you guys very much.